Good morning. I'd like to welcome everyone to our talk today. It's really a highlight for us to share our team's perspective on detecting, managing cardiogenic shock and defining exit strategies. And really the focus is to highlight the hub and spoke approach we are pursuing related to our system management of cardiogenic shock. And so we have an exciting group of discussants that are integral members of our cardiogenic shock team. And we're going to start off with Dr. Ziad Taimeh. He's an advanced heart failure specialist here at main campus. We were fortunate to recruit him from Texas Heart, where he was leading a number of initiatives, including cardiogenic shock. And as you will appreciate, our team consists of advanced heart failure representation, specialist involvement, critical care, surgical, interventional, and others. And so we're delighted to have this platform, and we're going to start off with Ziad.
Hi, good morning, everyone. So I'll be talking a little bit today about the concept of cardiogenic shock teams and where this evolved and where our position here at the Cleveland Clinic focuses on. So especially from a heart failure perspective, and I have no disclosures or conflicts of interest. In the past decade or so, the medical community have been realizing that we are having a rise in patients needing advanced heart failure therapies. We have an advancements in care for patients with ischemic cardiomyopathy, a rise in patients with valvulopathy, and rise in patients with advanced electrophysiological treatments. And our hope at the end is for patients' recovery. However, with advancement in their critical, clinical condition, we're in a situation where seeing more and more cardiogenic shock patients. And as such, the community have evolved into these critical care pathways to assist those patients. And patients with cardiogenic shock, as such, we start with treatments with inotropic therapy and as standards of care. And if we don't have any response, obviously the treatment is tailored based on the patient's problem. However, if perfusion is still a problem, then that's where the temporary mechanical circulatory support devices come into play, such as intra-aortic balloon contrapulsation, via ECMO, peripheral ventricular assist devices such as microaxial transvalvular devices and paracorporeal implanted devices. As such, our hope at the end of the day is really for myocardial recovery or palliative care. But there is a subset of patients, like I said, it's been rising and increasing in numbers, where those patients need a bridge to next, which is a durable ventricular assist device and heart transplantation, simply because they are not a palliative candidates. They are younger generation, younger folks, people with more hope to live. However, we're not expecting their recovery. And as such, the medical community have evolved, especially in the heart transplantation route, where we hope to get patients into with new regulations and new policies. In 2018, the United Network of Organ Sharing, which is the affiliate government affiliate that manages donor hearts in the United States, came up with a new sets of heart allocation policies, and it's tailored toward patients with cardiogenic shock with a more depth risk stratification and very strict criteria about what are the criteria that has to be set for the patients to be listed and at which tier, as well as informing more listing time frame and very strict windows for treatment. And as such, the prior system involves patients with status 1, status 2, and status 7. Now, the new criteria, it evolves to status 1 through 6. And going through this is very important because thinking about this beforehand when we have a patient with cardiogenic shock, even before device implantation, is very critical. And patients with status 1, those are the patients that come to the unit in a crashing and burning status, needing to be crashed on VA ECMO. After they're stabilized and they're deemed a transplantation candidate, then they could be listed on the waitlist transplantation list up to 7 days. After those 7 days, rejustification has to be made why this patient needs to remain in status 1. Status 2, those are patients with an intra-aortic balloon pump or a transvalvular microaxial flow device, patients with VTVF without MCS support. Status 3, those are the patients with multiple inotropes in the ICU. Status 4, patients with a durable LVAD sitting, being treated at home. Status 5, multi-organ transplants, and status 6, all other candidates. So this system has been precisely tailored to assist those patients based on their sickness, but at the same time, each one of these devices have a very strict criteria whether they which tier and which status they would fit in. It's very important to note that they have time frame, meaning that to list somebody with VECMO status 1, that patient should have had the ECMO with stricter criteria of why this patient meets the eligibility for ECMO within its 7 days, I believe. And you can keep that patient on the transplant list for 7 days as well. So time frames are of essence here. So as a heart failure specialty, there are multifaceted involvement as start with the temporary MCS device selection, the bridging strategies, and really what's next, I think is very critical. Then we have indications and contraindications for VAD and transplantation, the transplant waitlist stratification and placement, and evaluation for that listing window, very important. At this current age, we're having more and more temporary MCS device use and pre-transplantation. If we can take a look here, this is a paper published in 2020 in JACC. It showed that patients who transplanted after ECMO support showed worse outcomes compared to other patients supported with temporary MCS before transplantation. This is to prove that patients with MCS before transplantation and device selection is associated with outcomes. So this is very, very, very important. Same thing here, patients with ECMO versus patients with BiVAD, temporary mechanical circulatory support, they do better. So if somebody coming, crashing and burning in the ICU, biventricular failure, that patient was triaged on ECMO, then a better strategy would be to switch those patients to biventricular support, temporary biventricular platform, because it's associated really with better outcomes comparing to transplanting them straight to ECMO. So this is very important to be placed in play at the beginning of the patient's journey in the critical care unit. Now, as VAD as well, we're having an uprise in the number of patients that have been bridged with a temporary mechanical circulatory support to LVAD or durable LVAD surgery. And this is the report that was published in 2018 in Journal American Heart Association. So we're having a rise in patients with temporary mechanical circulatory support devices and patients with pre-LVAD cardiogenic shock, simply portraying the fact that our modern technology and our modern medicine is resulting in more and more patients with advanced heart failure issues that the hope for recovery has been really going down, and we need more than just medications. And again, this shows that patients who are bridged with mechanical circulatory support devices for LVAD surgery after ECMO associated with worse outcome compared to the other devices. So device selection is very important in this area. Same thing here, ECMO compared to all other temporary mechanical circulatory support devices, outcomes here are worse compared to the other treatments. So that's where this takes us. It takes us to the involvement of the cardiogenic shock teams throughout the country. And here at the Cleveland Clinic, we have a cardiogenic shock team that have been evolving throughout the last few years and focusing on the fact that the patients with cardiogenic shock are very ill. They need a multifaceted care involving different specialties. And we focus here on our colleagues with heart failure, cardiac surgery, interventional cardiology, critical care cardiology, and heart failure cardiology. Those multidisciplinary team would huddle 24/7 helping patients with cardiogenic shock, try to get them the best treatment strategy for the short term and quickly for the long term as well. So our mission is a 24/7 consultation service designed to facilitate early treatment of shock, cardiogenic shock primarily, as well as to triage the use of temporary MCS. Our vision is to improve survival of our patients via efficient and cost-effective pathways. Our structure, we have cardiovascular surgery, heart failure transplant on-call staff, heart failure cardiology staff on call, critical care cardiology on call, and our interventional cardiology staff on call as well. With a click of a button through either paging our on-call shock fellow or through contacting the transfer center directly, patient gets to be evaluated and the shock team on-call members get to be huddled so they can meet and discuss the case 24/7 with the referring providers. And by this, I would end my talk and welcome Dr. Mangeet Chahal, our colleague from our regional cardiology, to talk a little bit more about our regional efforts. Thank you.
Thank you, Ziad, for that fantastic introduction. And I do want to take the opportunity to introduce Dr. Mangeet Chahal. She's a member of our heart failure team. She's an advanced heart failure specialist. She completed her advanced heart failure training at The Ohio State University, and we were fortunate to recruit her. She had a lead role in Toronto to really improve access to care for advanced heart failure and shock platforms. And so we were excited about her current position, which is leadership one related to heart failure in the region and specifically at Fairview. And so she's going to highlight opportunities for a regional hospital and really link how the vision ties into our main campus initiatives. Mangeet, delighted for your presentation.
So thank you, Jerry, for that wonderful introduction. I'm going to be talking about regional systems of care for cardiogenic shock and opportunities for a regional hospital, Fairview and Hillcrest Hospital. So my objectives here are quite simple. I just really want to talk about why this is important and how does Fairview and Hillcrest really fit in so that this is sort of that final puzzle piece that makes this entire process successful. So regional systems of care have been in place for other time-sensitive conditions like STEMI, stroke, aortic dissection. And we know with STEMI, we've used a hub and spoke model with respect to integrating regional and tertiary care hospitals to improve quality outcomes. And we've all seen that in the last decade, the mortality from ST elevation MIs have gone down dramatically. But one area of STEMI that's resisted the tides of change is acute myocardial infarction secondary to cardiogenic shock. And that has had a mortality of more than 50% for quite some time. Now, recently, since 2016, there has been the development of cardiogenic shock systems of care. And as Ziad was saying, the focus has been on multidisciplinary teams. So an intensivist, interventional cardiologist, a advanced heart failure cardiologist, and a cardiac surgeon. And with multidisciplinary teams, we have seen the short and long-term outcomes from cardiogenic shock improve. This is data from Dr. Tirani's group at the Innova Heart and Vascular Institute in Virginia. And it demonstrates that using a team-based approach, a multidisciplinary team-based approach, with a focus on early recognition of cardiogenic shock, early hemodynamic monitoring, and early use of temporary circulatory support, we have been able to improve the survival to hospital discharge. And as you can see here, survival has improved up to as high as 87.5%. So, one of the most successful regional systems of care models has been the hub and spoke model. So a hub is a high volume tertiary care cardiovascular center with a multidisciplinary shock team, and that is the main campus here at Cleveland Clinic. Now, a spoke is a regional tributary hospital with less on-site capabilities. So a level 3 spoke hospital would be a non-PCI capable hospital, and a level 2 spoke hospital would be a PCI capable hospital, but they may not be as well equipped to deal with acute mechanical circulatory support devices in the long term. And so if a patient presents in the field with cardiogenic shock, as you can see up here at the top, or at a level 3 hospital with cardiogenic shock, in this diagram, it's secondary to acute myocardial infarction. they should be transferred to a level 2 spoke hospital for early revascularization and stabilization and consideration for placement on a support device with a goal of first medical contact to support time of less than 90 minutes. But if the transfer time is greater than 120 minutes, then they should be transferred directly to a hub hospital. Now you can see on this diagram there's a traveling shock team or a shock mobile, and that consists of a cardiac surgeon and a perfusionist and a nurse. And here at Cleveland Clinic we do have the ambulance, but we also have the helicopter and we have the private jet. And so time to first medical contact will depend on the mode of travel. Now this entire system works based on good communication between the physician at the level 2 hospital and the physician at the level 3 hospital, and a good transfer call center that makes this entire process efficient. So great, but how do we actually do this? Well, we know that success always leaves clues. And so one of the earliest regional systems of care models for cardiogenic shock using the hub and spoke model was back in the 1990s by Columbia Presbyterian Hospital, led by none other than Dr. Mehmet Oz's group. And so what they addressed was they had an issue with their post-cardiotomy shock patients receiving care, or temporary circulatory support care for their patients from their regional hospitals within a 250-mile radius. And survival to hospital discharge back in the 1990s, secondary to shock in New York, was 25%. And with the implementation of a hub and spoke algorithm, the Columbia Presbyterian Hospital was able to improve their survival to hospital discharge rates to as high as 74%. But it wasn't until 2011 when Mayo Clinic in Arizona, following in the footsteps and leadership of Columbia Presbyterian Hospital, developed their own hub and spoke algorithm using a traveling shock team as well. And they improved their survival to hospital discharge from 25% to as high as 56%. And then most recently in 2016, the Detroit Cardiogenic Shock Initiative, which started as a pilot program of 4 hospitals in Detroit, who had agreed that they would manage their acute myocardial infarction patients secondary to cardiogenic shock based on a best practice algorithm led by Dr. Bill O'Neill out at Henry Ford Hospital. And that algorithm focused on early recognition of cardiogenic shock, early hemodynamic monitoring, so placement of a right heart cath, and temporary circulatory support placement. And with that implementation of that algorithm, they demonstrated significant improvements in their survival to hospital outcomes, significant improvements in their outcomes with respect to survival to hospital discharge, as well as 30-day mortality rates. And what started off as 4 hospitals in Detroit has now morphed into 65 hospitals worldwide that has adopted this algorithm, and it's now called the National Cardiogenic Shock Initiative, or the NCSI. So that's all well and good, but why is that important now? Why is that important to Cleveland Clinic in 2021? Because we know now. We know now that cardiogenic shock survival improves with a multidisciplinary team approach. It also improves with early recognition of cardiogenic shock, and my colleague, Dr. Rampersad, will be speaking more about this. It improves with early hemodynamic monitoring, so with right heart catheterization placement, and it improves with early placement of temporary mechanical circulatory support. You can see here that as the number of inotropes increase, survival decreases in a stepwise fashion, such that by the time you have more than 4 inotropes, the survival is only 26%. But if you place a temporary circulatory support device within the first 85 minutes, survival is 66%. If you wait more than 4 hours, 26% survival to hospital discharge. So how does Fairview Hospital and Hillcrest Hospital fit into all of this, the hub and spoke model? So Fairview and Hillcrest are type 2 spoke hospitals. And at Fairview, we've already developed our multidisciplinary shock team consisting of an intensivist, interventionalist, cardiac surgeon, and an advanced heart failure cardiologist. And we are working on algorithms and education towards early recognition of cardiogenic shock, early placement of a right heart cath for hemodynamic monitoring, and then early temporary circulatory support. And whether that means just cannulation for ECMO and shipping, placement of an Impella, placement of a balloon pump, our goal is first medical contact to support time of less than 90 minutes. And so I just wanted to give you sort of a brief overview of what we're doing and why we're doing it. We will save questions to the end, and I will introduce my colleague, Dr. Penelope Rampersad. So Dr. Rampersad is a critical care cardiologist. She joined our team in 2017. She is a long-term friend as she completed her internal medicine residency, cardiology fellowship, and adult congenital heart disease fellowship from the University of Toronto. She also has a master's in cardiac physiology and completed her critical care fellowship here at the Cleveland Clinic. She is an expert at speaking about cardiogenic shock and mechanical circulatory support, given her background in cardiac physiology and critical care, as she understands the physiology and the dynamics that come into play with these complex patients. So please join me in welcoming Dr. Rampersad.
So I'm going to be speaking a little bit about the critical care perspective in terms of managing patients with cardiogenic shock and triaging them. We've identified that systems of care are important, and having a hub and spoke model allows us to quickly mobilize patients, but some of the challenges that come along with operationalizing an outfit like this are challenging, and first identifying patients early on and selecting them, then allowing for quick timing in terms of deploying resources, having a systematic approach to that, figuring out when it's appropriate to utilize adjunctive therapies and tools, figuring out how to escalate or de-escalate care when indicated, figuring out long-term strategies, and then making sure that there's equity and accessibility across regions to all of these types of technologies. So speaking about cardiogenic shock, and just to show you a quick pathophysiology slide, I always talk to my trainees about there being a golden hour, just like we speak about in trauma for cardiogenic shock, and that it's a slippery slope that once patients initially present, the cascade begins and there's a vasodilatory response which ends up happening with that. And the further down that pathway you intervene on patients, the worse the outcome will be. So identifying patients early on and having a definition for that is very important. And one of the deficits that we see in the literature is truly defining cardiogenic shock. And through, as time has evolved, thinking about initially acute MI patients to a broader group of cardiogenic shock patients, that definition has evolved. Typically, we still define cardiogenic shock as evidence of clinical and metabolic hypoperfusion or biochemical hypoperfusion despite adequate filling pressures. This is a contemporary look at a network of hospitals within the US and ICUs, and looking at all patients admitted to CICUs and the etiology of their shock. And within that, you can see that in the red panel that cardiogenic shock accompanies about 66% of patients, but the rest of shock pictures of patients can be mixed, distributive, and there's a lot of overlap. It becomes difficult to identify these patients early on. And typically thinking about causes of cardiogenic shock, over in the second panel, ischemia, which we traditionally thought of as the most frequent cause of cardiogenic shock, accounts for only about 30%. We see patients now presenting with chronic conditions, chronic ischemic cardiomyopathy, which becomes acutely decompensated valvular heart conditions. Other causes of obstructive cardiogenic shock are all possibilities. And it doesn't really matter in terms of what type of shock it is, whether it's acute MI, cardiogenic shock without acute MI, or mixed shock picture. All of these patients suffer from a terrible mortality ranging somewhere from the high 20s to 40%. So there was this recognition within the literature that there's variable definitions, there was a lack of evidence to support our device selection, and a variation in practice patterns amongst patients. And with that came out the AHA statement scientific paper a few years ago, trying to figure out how we regionalize and manage patients with cardiogenic shock. You've seen this slide talking about systems of care. And really, my team within the ICU falls in this phone call here and receiving that triage call. Typically, that's going to be one of my fellows within the CICU who's receiving that call. And one of the ways that we looked at trying to standardize that communication between providers is having a terminology to describe those patients. And with that, and with the idea that we would try and progress this field and make it more academic and rigorous in terms of how we look at patients, there's been a new definition or classification which has been developed in the last few years called the shock classification. And it really looks at patients kind of A through E, looking at patients who are at risk, beginning stages of shock, whether or not they've got classic symptoms of shock where there's an intervention which is required, deteriorating patients or patients in extremis. And Jacob Jenser's group out of Mayo looked at this patient in a single center here, but has also been validated in a number of other populations, looking at these patients as their shock or SCI classification increases. There's also a decrease in mortality or an increased mortality, which is seen in those patients. So for me, I'm thinking about effective early triage in these patients, and that's really reliant on providers seeing the patient at the bedside, whether that's in the emergency department, on the floor, in the ICU. And how to identify those patients is difficult, and there needs to be a level of suspicion that cardiogenic shock is in the mix. And also thinking about how we appropriately select patients. And typically some of the things that we're looking for on the phone call, thinking about our patients' candidates, are whether or not they have, DNR, DNI pre-existing, advanced directives, whether or not they might be relative contraindications such as over the age of 85, or have mortality, which we think is limiting them to a life expectancy of less than 6 months. You've seen this slide in terms of cardiogenic shock management pathway. I'm just going to highlight the top box here, thinking about that initial resuscitation, whether that's inotropes, mechanical ventilation, and etiology. So really, when we start thinking about this pathway and we receive that call, we're going, okay, what's the etiology, trying to decide what's the best intervention which is necessary. And differentiating the etiology becomes very difficult and ends up becoming not always what the provider on the other end of the phone can identify for us, but sometimes needs to be differentiated once patients get to us. So just that early recognition, placing that phone call saying, hey, we need help. And then the work begins once patients arrive for us to define that a little bit more. One of the ways that we define that better is typically with a PA catheter or a Swan-Ganz catheter. And this is just some observational data in a single center in North Carolina, but really looked at patients in cardiogenic shock either being admitted to a CICU or a non-CICU, another ICU, and just looking at the frequency of Swan-Ganz catheter use within that population, which was much higher. And a more recent study by the Cardiogenic Shock Working Group, which looked at patients who were with incomplete assessment by PA catheter or with complete assessment. And as SCI classification escalated, seeing that these patients actually fared better if they had full hemodynamic profiles allowed for them. So one of the reasons to push to get patients to CICUs or capable places where we can adequately differentiate and then tailor therapies is to allow for that assessment. Dr. Soltesz is going to continue on shortly here and speaking a little bit more about how we go down this pathway. But I would say within the critical care sphere, whether it's bridging patients towards these more durable destination therapies, whether it's transplant, there are a certain number of patients who will recover. A number of patients will also go on to palliation, and we really kind of serve as that glue or that quarterback to communicate with all of the teams to allow that conversation to happen and to work with families as we go through that. The critical care team requires that we're able to manage all of these devices, think about all the other critical care bundles and pathways that go along with that in terms of making sure that we have a quality outcome for patients. So in summary, we've got a highly morbid population, working to identify early these patients and select them appropriately, to think of temporary mechanical circulatory support in a timely way, working with our regional partners to do so, and then speaking further about this multidisciplinary team, which Dr. Soltesz will go on to. Thanks for your attention.
Okay, next I have the privilege of introducing Dr. Soltesz. So Dr. Soltesz is the surgical director of the Transplant and Mechanical Circulatory Support program here at Cleveland Clinic. He is a native of Cleveland and did his medical school at Harvard Medical, and then went on to do his general surgery fellowship and cardiovascular fellowship at Brigham and Women's in Boston. He also has a master's in public health and has a additional fellowship here at Cleveland Clinic in complex aortic and endovascular surgery. and has joined the team since 2008. Now, we're really privileged to have him as a leader in the advanced heart failure field, as he is also the surgical director of the affiliate programs, which means he oversees surgical outcomes, quality outcomes, and growth and expansion of our regional programs. So please join me in welcoming Dr. Edward Soltesz.
Well, Mangeet, thank you very much, and I appreciate the opportunity to speak here today. I'm going to really focus on our opportunities to leverage the hub and spoke model of cardiogenic shock care with the shock team that uses a multidisciplinary model, including cardiac surgery, cardiology, ICU, nursing, social work, all the above, to really try to take a stab at reducing the mortality in cardiogenic shock patients. And we know, and we've seen this before, that cardiogenic shock starts off with a hemodynamic problem. It starts off with a pump problem, but very rapidly progresses to a hemometabolic problem, and that is to say, complete increase in systemic inflammation with inflammatory cytokines upregulated throughout the body, vasodilatory shock combined with a cardiogenic shock picture. So really, what we're talking about is not simply a pump problem when we eventually see these patients. This needs to be understood as truly a hemometabolic problem. Now, the goals in cardiogenic shock care has been highlighted already, really is the early recognition and triage of these patients through standard diagnostic criteria that utilize defined classes and stages of cardiogenic shock. It's important to be able to speak the language of shock when we're describing patients. Of course, it's more important to actually identify the problem before we do progress down that irreversible road of cardiometabolic collapse. But more importantly, once we've identified shock, the goal of care is to utilize a multi-modality assessment of shock and end organ function within the context of a multidisciplinary shock team. And that's the middle section from 4 to 9 here, where the shock team functions critically in identifying these patients, determining the trajectory, and starting appropriate therapy, whether it be early revascularization or inotropes, or more commonly, where I get involved in my team, the use of mechanical circulatory support. And then from that point, continuing the care model to either rapidly escalate or de-escalate care as necessary. And we call that here the tailored approach to cardiogenic shock therapy. You've seen this before, but I just want to highlight that when we talk about mechanical circulatory support, we're really speaking to intervene in stage C, D, and E, where we're trying to curtail that high morbidity and mortality that we see on the right there, and hopefully drop some of these statistics into the more manageable and reasonable range. We know that there are certainly limitations to some of the established therapies, and this is why mechanical circulatory support has become more prominent in our armamentarium over the last 4 to 5 years. There's a significant increase in mortality risk with the additional use of more than one inotrope or vasopressor. And we've also seen through a number of trials, not all trials, but a lot of trials showing that balloon pump therapy is not statistically different than medical therapy, although that is not borne out in some other trials. So that's why we've seen, both here at the Cleveland Clinic as well as really throughout the nation, an increase in the utilization of mechanical support devices. Here I'm characterizing our use of Impella device and VA ECMO, and you can see even despite COVID in 2020, and this is only for VA ECMO and VAV ECMO, you can see a significant number of these devices were utilized last year, and we are on pace to beat all of these previous years this current year. So the goals of temporary mechanical circulatory support are really to restore adequate end organ perfusion, unload the injured ventricle, both from a pressure and a volume perspective, and allow a safe bridge to either recovery, transplant listing, or permanent device placement. And really what this also allows us to do is buy some time and understand goals of care from each individual patient's and family's perspective. When you look at it from the view of the hemodynamics, you'll see that we want to increase mean arterial pressure, that is, maintain systemic perfusion, while at the same time reducing myocardial oxygen demand as measured by left ventricular end diastolic pressure and left ventricular work. Now, we have a number of devices available to us to utilize in this regard here at the Cleveland Clinic, and I've listed the 4 most common devices that we utilize: ECMO, tandem heart, various configurations and types of Impella, and then the CentroMag device, which is a surgically implanted device. I've listed these all from least ability to unload each individual ventricle to most, and then from least ventricular specific support to most. And as you can see, the CentroMag, which again is an implanted device, has complete ventricular specificity and biventricular unloading capacity. But of course, this is a surgically placed device, whereas some of the others listed here are much more minimally invasive. When we come to see a patient in cardiogenic shock, and really we're talking about stage D and E, our immediate focus is to understand what part of the heart needs support, how much support is needed, and how quickly does that support need to be deployed. There are a number of different devices that we utilize, and they can be characterized by their ventricular specificity. I list here balloon pump. It's a counter pulsation device, so it really does not have any ventricular specificity. It does provide reduction of afterload and increase in coronary blood flow, but unfortunately does not increase cardiac power output or cardiac output very much. But if you look at these other devices, you can see there are LV-specific devices, such as the various types of the left-sided Impella devices, CentroMag and tandem heart. There are RV-specific devices, such as the Impella RP, again, a different configuration of right-sided CentroMag and the Protect Duo cannula, as well as right-sided implanted ECMO. Notice that neither LV-specific or RV-specific has ECMO, the VA ECMO, because VA ECMO is a biventricular support device. And the other configurations of devices, such as CentroMag and Impella, can be utilized as a biventricular support, but you need 2 devices, 1 for each side of the heart. And then finally, if there's an oxygenator in place in some of these devices, you can provide full cardiopulmonary support. Also noted here in green is the ability of each of these devices to directly unload the applicable ventricle, whereas some devices, namely the tandem heart, provide indirect unloading, and some, such as ECMO, provide no unloading. We can also understand temporary mechanical support from the degree of support that's provided. Note that balloon pumps provide anywhere from 10 to 15% increase in cardiac index, whereas the others are much more robust and typically provide near full or full support. I want to highlight the importance of ventricular unloading. And obviously, in cardiogenic shock, there's an increase in end diastolic pressure and left atrial pressure. And then with directly unloading the left ventricle, we see that drop in left ventricular end diastolic pressure and left atrial pressure, which results in increased coronary and microcirculatory flow, decrease in the mitral regurgitation, and decrease in RV afterload, which indirectly improves right ventricular function. So many times what we see after placing a left-sided device is actually improvement in right ventricular function over time, so as to not even potentially need a true biventricular support device. I think it's also important to highlight the different devices that we have and utilize most commonly. We typically have VA ECMO and Impella, the axillary 5.5 Impella, as our go-to devices for acute MCS. And we use these in different situations, leveraging their advantages and disadvantages. So VA ECMO can be placed rapidly. In fact, it can be put in at the bedside. It's totally percutaneous and provides full immediate cardiopulmonary support. Unfortunately, it does not unload the ventricle. There's a significant amount of hemolysis because it's extracorporeal blood flow. And in the configurations that are placed emergently, it really does not allow for ambulation of the patient. Whereas the Impella 5.5 is placed to the right axillary artery in the operating room, and this is a direct active LV unloading device. This is a microaxial transvalvular flow pump. There's minimal hemolysis with the 5.5 device. This allows for full ambulation. It's very durable, but it only supports the left ventricle. And you have to go to the operating room to place this, so there is a significant time component that is needed. Now, we and others have advocated for LV venting or unloading shortly after placement of a patient on VA ECMO. And in this circulation heart failure paper from 2 years ago, as a review and meta-analysis, we found that if this is done within 12 hours of initiating VA ECMO, there is a significant increase in successive weaning and reduced short-term mortality in these patients. And this is borne out in a number of different studies comparing ECMO with Impella as an direct LV unloading strategy compared to ECMO with the balloon pump, which is we traditionally used in the past. So this takes us really to our tailored shock strategy. And this is, again, for the patients who are in cardiogenic shock with imminent cardiopulmonary collapse. Those are those stages D into the E category of shock. We mobilize our shock team, and we typically cannulate these patients either here at the clinic in various different locations or even assist with cannulation at an outside hospital for percutaneous VA ECMO. We always use reperfusion sheath in the groin so as to mitigate limb ischemia, and we monitor we do spectroscopic limb monitoring, again, to help forestall any problems with limb perfusion. Now, within hours, usually 6 to 12 hours after placement of VA ECMO, we want to find ourselves in the operating room. We call it tailoring the therapy at this point. We'll implant an axillary 5.5 Impella, and at that point, determine if we need continued VA or potentially VAV ECMO support with Impella as an LV vent. Sometimes the hemometabolic issues have not completely or near completely resolved, and we want additional time with full support. But majority of the time, we actually can transition to a ventricular-specific unloading strategy. That is to say, most of the time, 95% of the time, we're able to wean VA ECMO and decannulate the patient right there, repair the femoral artery directly, and be left with only a left-sided Impella axillary support that allows the patient to get extubated soon thereafter and ambulate, or at least sit up in bed. Occasionally, we need full biventricular support, and we'll transition from VA ECMO and add an RVAD, whether that be an Impella RP or a Protect Duo through the right IJ. Or sometimes we encounter respiratory failure as a component and need to switch the VA ECMO to VV circuit along with the axillary Impella. So again, this is tailoring the device therapy so as to achieve a ventricular-specific unloading strategy as the end game. And you've seen before how the outcomes are better when you have a ventricular-specific strategy. So no one single device really is appropriate for all situations and conditions, or even the continuum of a patient's cardiogenic shock. ECMO, we know, is inexpensive to rescue a patient, but it's not ideal for myocardial recovery or to ambulate the patient, whereas the Impella device promotes myocardial recovery, ambulation, and can test the right ventricle to see if we can actually use a durable LVAD as a final exit strategy, or do we actually need biventricular replacement strategy like transplant. We know that ECMO with Impella, the Impella circuit, is a better strategy for LV unloading than ECMO with the balloon pump. But most importantly, I think a shock team, protocol-driven approach where we continually reevaluate our strategy with the goal to achieve a ventricular-specific unloading support is really what sets this strategy apart from so many others. Now, you've heard a lot about the shock team. The strategic opportunity here really is to facilitate access of these critically ill patients to life-saving therapy, and specifically to some of these mechanical circulatory support devices I just mentioned. But it's also to integrate research, quality, and clinical data. You've seen this before. Our shock team really composed of a number of different care providers with the patient really at the center. And the goal of the shock team always is to identify the endpoint, select the initial device, tailor the device, and continually reevaluate the endpoint as we understand the patient's and family's wishes and capacities. Again, I'll highlight that not only do we mobilize the shock team in hospital, but out of hospital transfers can use the same triage system as in hospital with the 2-shock paging system. We know that shock teams improve survival. There have now been 2 publications outlining shock teams and a protocol-driven approach with a resultant increase in outcomes with the significant decrease in mortality. So what can your center offer 24/7? Well, we're level 1 here. We're large academic medical center, and we have, as highlighted here, multiple percutaneous and surgical support devices, as well as the exit strategies available, the VAD and transplant. Level 2 programs are those larger community hospitals and some teaching hospitals. Our regional hospitals really fit into level 2, where they have a STEMI program, but they also have embedded within that a number of percutaneous devices and surgical support systems available to resuscitate a patient and allow for transfer. Then there are some smaller community hospitals that have very limited or no percutaneous support devices. The hub and spoke model really allows us to utilize and leverage this whole system and really bring it to fruition with shock care. So in conclusion, I would say that unfortunately, cardiogenic shock mortality still remains poor. I think early mechanical support with LV unloading is key to improved outcomes, and we can improve outcomes even more so if we really leverage our multidisciplinary, protocol-driven shock team approach with the hub and spoke model of regional care, minimize use of inotropes, early placement of temporary MCS, and truly embrace the tailored therapy, that is escalation or de-escalation as needed, understanding that no one device serves all purposes. Thank you.
We have a solid 10 minutes left to really, most importantly, address questions from the audience, and we encourage that, and also look forward to a robust discussion along a number of points. So we'll jump right into questions from the audience. An intensivist, one of our colleagues, notes or writes, apart calling Q-shock, what can we do to prepare the patient to cannulation? What lines do we have to place while we are waiting for the ECMO team? So who would like to address that? Penelope,
I can take that. So apart from calling us and thinking about what needs to be done for the patient, is characterizing their hemodynamics, I think, is the most important thing for us to figure out what device is needed, and that might not necessarily be ECMO. So if you can give us a quick synopsis of what the patient looks like, their neurologic status, evidence of end organ hypoperfusion. We want to know what their kidneys look like. We want to know if their liver is working. We want to know if they have evidence of coagulopathy. And then if we can characterize what their heart is doing. So if we know what the etiology is, if you've done a bedside echo, if you have a formal echo, ideally if a Swan-Ganz catheter had been placed, that might not be within the capability of all ICUs. So best information that you have would be important. If you're thinking about, and we're suggesting to you that we need some kind of percutaneous access, typically we usually just get patients to have femoral lines in, just simple central line access, which we can wire over when patients arrive. I don't know, Ed, if you'd like to add to that.
Yeah, no, I think that's perfect. I think getting actual hemodynamic data is very important to guide our discussion within the shock team as to what's the best device. But I would say that it's always easier to place femoral arterial line, especially when you have a pulse. So I would advocate putting in a femoral arterial line. We can always rewire that and appropriately upsize that as necessary, as well as a femoral venous line. They can be on the same side, they can be on different sides. Ideally, a venous line on the right side, because it's a straight shot for a venous ECMO cannulation up into the right atrium.
So along the lines of preparing the team to have enhanced decision-making, hemodynamic monitoring has been alluded to. And so I want to just get the opinion of everyone on the panel for, let's just say, all stage CDE shock patients. Should every patient have a Swan-Ganz placed early up front? So we'll start with Ziad, and then Penelope, Ed, and
That's actually a very good question, and the issue of a use versus not use of pulmonary artery catheter has been under scrutiny for so many years. There are a couple of publications coming out in the contemporary era showing that the pulmonary artery catheter use is associated really with improved outcomes. Now, we are biased here at the Cleveland Clinic. Pretty much we use PA catheter on everybody that's we're suspecting cardiogenic shock. I mean, at the end of the day, We have to tailor the therapy based on the patient's cardiac function, not just the overall status. As such, we would evaluate does the patient have RV failure, predominantly LV failure, biventricular failure. So the important data that we get from the PA catheter is really critical for the management and triage. Now, that being said, if you have a tailored approach toward the primary problem, let's say if you have severe myocardial infarction, you revascularize, you can tell the LVDP is very high, putting in a transaortic microaxial device might unload the ventricle properly and improve the hemodynamics without the need of the PA catheter. But nonetheless, majority of our patients are really in need for more tailored approach, and the PA catheter, I think, is appropriate in those cases. So I'm an extremely supportive person of using PA catheter in those patients.
Penelope.
Yeah, I would agree, absolutely. That's my bias, and that's what I presented. I think I wear a couple of hats because I'm both cardiology and critical care trained, and the critical care literature would suggest that PA catheters maybe don't add to management of patient. What I would note from those studies is that they never looked at cardiogenic shock patients in that management. So I think the PA catheter is paramount unless we have an absolute contraindication like something such as, endocarditis or a severe RV thrombus or something that would preclude us from getting that information. For me and management of patients, I want every little bit of information I can get so I can be as informed and tailored as possible.
Yeah, no, I would echo supportive use of PA catheter. I think it can be placed relatively expeditiously with ultrasound guidance so as to minimize complications, and it really does add to the data that we have available to guide our selection of devices. And also the timing of triage. I mean, one of the most important things, I think, is to understand how quickly do we need to establish mechanical support, and that can clearly be guided with hemodynamics.
Mangeet?
So I agree. I echo what's been said here 100% in terms of Swan-Ganz placement. And also, based on the literature, we know, as I showed with the National Cardiogenic Shock Initiative and Dr. Tarani's work in Virginia, the survival improves with placement of hemodynamic support and actually following the numbers. Yep, so I agree.
So a consistent, clear message, and I think that's super important to highlight. Let's take advantage of system goals related to competencies in education. And Mangeet, if you can just highlight what our colleagues in the region should be on the lookout for as it relates to modules, education, events at the local level, in terms of what defines competency related to managing this patient population.
So I think one of our main goals in the region will be early recognition of cardiogenic shock, and that is a heterogeneous presentation. And so I think just moving towards more educational processes in that factor. And as we see more and more cases, to have more and more of our teammates involved to see that maybe it's not going to be your classic acute MI cardiogenic shock, but it's going to be your more acute compensated heart failure from myocarditis, et cetera, and just sort of bringing the whole team in as we see more and more of these more complex cases.
Yeah, most excellent. And Ed, as our colleagues in the region are considering this patient-specific, ventricular-specific approach, it certainly implies having an understanding of weaning. And I know we've talked a lot about weaning protocols and best practice. If you can just, for the audience, highlight some of the big concepts related to device weaning. Perhaps a patient is supported by an Impella CP and is doing well, and they want to consider whether the patient merits an exit strategy like transplant or LVAD. Perhaps the patient has gotten better. We know certainly that may not hold true for one can argue the majority of patients, but if you can just highlight some concepts related to device weaning consideration.
So I think it's important. It's extremely important in device weaning to understand what the exit strategy is. If you have a patient who is only a recovery-only opportunity, then weaning, of course, guided by sort of standard practices that we actually just had an opportunity to publish a great paper on weaning and the practice of weaning various different types of mechanical support devices. However, if you have an exit strategy that is a durable LVAD or potentially transplant, a lot of the time on device as well as hemodynamics during device management impact what status you would be for transplant consideration, as well as whether or not you qualify, for instance, according to CMS DT criteria for a destination LVAD. So it's important to talk with us, talk with our the heart failure staff and team here to understand what that looks like. I think the most important thing we want to realize is cardiogenic shock is a sentinel event. And if you get admitted with cardiogenic shock, that truly is a life-turning moment for that patient and for that patient's family. We certainly don't want it to have to happen again. I think that the worst situation is when we see someone who's weaned off a device too early, and then we're back putting the device back in. That's really a never event. So we clearly want to establish protocols and practices, which we have alluded to in a paper we recently published. But also the key is just to involve our heart failure team so that we understand where we're going. What is the end game involved for each individual patient?
So perfectly said, and it is now 8 o'clock, and I want to thank each speaker and integral team member for just a fantastic overview. And I hope it is clear that we appreciate that we're in this together, and we're seeing our team with extension into the region, and really with this system perspective, we hope to ultimately better care for patients that are suffering this cardiogenic shock syndrome. And so I'd like to thank the audience for their attention and for their good question. And this will conclude today's session. Thank you.